Good morning. We'll move on to our first short case discussion. The first patient is a 20-year-old gentleman, an ITI student, who presented with weakness of both upper limbs of 3 years duration and weakness of both lower limbs of 1 year duration. So the patient was apparently well 3 years back when he first noticed some difficulty in raising his arms above his head while playing volleyball at school. He subsequently noticed that he had difficulty in combing his hair, carrying a mug full of water, as well as while wearing his t-shirts. However, he had no difficulty in mixing his food or in buttoning his shirt. He also noticed progressive thinning of the limbs. Following this, for the past year, he noticed that he had difficulty in getting up from squatting position and also in climbing up the stairs. He had a difficulty in getting up from the bed by himself without support and mild breathing difficulty on exertion. He did not have any symptoms of twitching, diurnal variation, fluctuation of his symptoms. He had no cranial nerve symptoms, no tightness, no involuntary movements, no sensory symptoms, no bowel bladder complaints. There was no history suggestive of passage of high-colored urine or no history of cramping pain in the limbs. Past history was not significant. He was consuming mixed diet with normal sleep and bowel habits. Her family history, he was born of a non-consanguineous marriage, firstborn, with 2 younger siblings who do not have any similar complaints. So summarizing the history here, so we have a 18-year-old gentleman who presented with progressive weakness of both upper and lower limbs with thinning of limbs. So considering this, the possible clinical localization is to the lower motor neuron. So the possible localizations can be 1 to the muscle, 2nd to the motor roots, or to the nerves. Moving on to the examination, his vitals were stable, general examination was normal, he had no significant skin findings, higher mental functions were normal, cranial nerve examination was also essentially normal. So motor system examination, on examination of the bulk, we noticed that there was some asymmetric hypertrophy involving the calf muscles. He also had a selective hypertrophy involving only the vastus lateralis. You can see the lateral aspect is appearing hypertrophied. The medial aspect seems to be atrophied. So on examination of the upper limb, so there was found that he had wasting of the anterior axillary fold, and there was a prominence of partial prominence of the biceps muscles. This is what we call as a biceps lump sign, which indicates selective hypertrophy of certain fibers of the biceps muscle. So on attempting to push against the wall, we noticed that he had winging of scapula with prominence of the infraspinatus muscle. So in this, we can see that there is winging of scapula with like a polyhill sign. So here there is a prominence of the infraspinatus with wasting of the posterior axillary region. The acromyoclavicular joint is prominent, trapezius seems wasted, and there is a deltoid wasting, and biceps, the upper fibers of the biceps seem to be hypertrophied, whereas the lower part seems atrophied. So while trying to get up from squatting position, so he has difficulty. We see that he is abducting his hip because the abduction is preserved compared to adduction, and he is using the support of himself to get up. This is what we call as a Gower sign. We can also notice that he has prominent lumbar lordosis. So examination showed symmetrical proximal weakness, predominantly involving the proximal and intermediate group of muscles, both in the upper as well as the lower limbs. His reflexes were preserved. The other systems, including sensory, cerebellar, and skeletal, spine, cranium, were all normal. Cardiovascular and respiratory examination was normal, and there was no evidence of organomegaly. So summarizing here, we have a 20-year-old individual with proximal predominant weakness of upper limb, lower limbs, and trunk with selectivity. So this is a limb girdle pattern of weakness. Considering the selectivity, the presence of proximal predominance of weakness, and the limb girdle pattern, most likely anatomical localization is to the muscle. So considering the young age of onset and progressive symptoms, etiology is probably genetic.
Thanks, Gomathi. So what we have seen is a very systematic presentation, history followed by examination and demonstration of clinical science also. So what is important to see is in the history what was very meticulously brought out is what was the topography of involvement, like in the upper limbs, whether it was proximal, intermediate or distal. Similarly in the lower limbs, whether it was proximal, intermediate, distal, whether respiration or cardiac system was involved. And also what is the temporal profile of progression, like it was like an insidious onset and very gradual progression in this case. So from the history itself we got the idea that it was a proximal predominant weakness of the upper limbs and the lower limbs with some mild dyspnea on exertion, and it was like a insidious onset, slowly progressive illness in a young adult, a 20-year-old male patient, which has been slowly progressing. So that's what gives us the clue to the limb girdle syndrome, what we call. So in this case, as Gomathi mentioned, because it is like a limb girdle pattern of presentation with, we actually found that there was a lot of selectivity of muscle involvement. That's why the diagnosis here is localization is more to the muscle. Just another short thing regarding in history, how do you get the patterns of weakness? Like very simple questions like for the upper limbs, like lifting a mug of water, combing your hair can indicate weakness of your very proximal upper limbs like your deltoid. Lifting up a small bucket of water could indicate weakness of your biceps. Your hand grip, of course, you can ask for history of difficulty in gripping. Similarly, for the lower limbs, like difficulty in getting up from a low-lying squat or from a chair can indicate weakness of the pelvic girdle muscles, mainly your hip extensors. Difficulty in climbing upstairs again can give a clue regarding the pelvic girdle weakness. Difficulty in coming downstairs, like many people, especially with this limb girdle weakness, tend to report that while they're coming downstairs, they tend to buckle at the knee. So buckling at the knee is one of the features to suggest that there is weakness of quadriceps muscles. And some of them give complaints that they have difficulty in clearing their foot while walking. So that indicates weakness of the tibialis anterior, or indicates that the patient might be having a varying degree of foot drop, that is difficulty in clearing the foot because of the foot striking the ground. So all these subtle histories can give important clues before you go on to clinical examination. And why you have to examine them in detail is because you want to see whether some muscle, this pattern of selectivity. Selectivity again means whether it is proximal or distal proximal, intermediate or distal weakness. Similarly, are there some muscles which are involved disproportionately, some muscles which are hypertrophied? Like in this case, we found that the calf was hypertrophied, though it was mild, the calf was hypertrophied. There was winging of scapula. Again, like winging can be because of deltoid, because of trapezius, or because of rhomboids weakness. In this case, you could demonstrate like a deltoid weakness. And also, you could find selective hypertrophy within the muscle itself. Like when you carefully examine the biceps muscle, a part of the biceps muscle was prominent, whereas the rest of the muscle was atrophied. So again, this indicates that some fibers of the biceps are hypertrophied, are selectively spared. Again, a very characteristic feature which can be seen in muscle diseases. You can proceed further.
We'll move on to the second case. So this is an 18-year-old gentleman who presented with complaints of walking difficulty of 3 years duration and fatigue. So he had difficulty in getting up from squatting position, difficulty in climbing stairs. He first noticed when he was trying to run in school, and he also had some episodes of buckling. He had history of fatigue. So there was no symptoms involving the upper limb or other systems. So family history was born to a second-degree consanguineous marriage, second born with no similar complaints in the family members. So here again we have a gentleman who's presenting with walking difficulty, difficulty in getting up from squatting, climbing stairs with no sensory symptoms, again having the similar pattern of localization. Examination, he was obese with a BMI of 26. Other domains were normal. So here we can see that there is some mild wasting over the calf muscles which are noted. Otherwise, the other muscles seems to be well preserved. So power of the upper limbs were normal in this patient. Lower limb, there was weakness of both proximal as well as distal. So the plantar flexion was weak. So reflexes were preserved and plantars were flexor. So you can see the gait. Mild waddling was there. So plantar flexion was weak. So while attempting to toe walk, the patient has difficulty. However, he was able to heel walk well. So the dorsiflexors are relatively preserved in this patient. This again shows. So he has difficulty in getting up from squatting position. So again, we have a similar kind of proximal predominant weakness of lower limbs with selectivity, limb girdle type with distal involvement. Again, here the localization is more likely to be muscle because of symmetricity and pure motor syndrome with preserved reflexes and selectivity of involvement.
So, can you just find out mention what could be the difference between these two cases in terms of presentation? Both are limb girdle weakness, but there are some striking differences. Like the first case had significant upper limb involvement, scapula winging, multiple polyhill sign, and had calf hypertrophy. Whereas the second patient was predominantly involving the lower limbs alone, exactly. And here the calf was wasted. And the first symptom in this second patient the second boy was that he had difficulty in walking on the toes, again indicating that the calf muscles are weak. So these kind of very subtle history points can help in differentiating different limb girdle myopathies.
So these are the main symptoms to be asked in a muscle disease: weakness, fatigue, pain, cramps, enlargement or thinning, and fluctuation of symptoms. So as sir had already mentioned, these are the different groups of muscles and how the history the patient will present with. So again, based on the pattern of weakness, if the patient has persistent weakness, so we can divide it into proximal more than distal with associated eye abnormalities like ptosis, extraocular movement abnormalities, associated facial weakness and facioscapulohumeral dystrophy with quadriceps myotonia, where there is difficulty in relaxing once they contract and relax. So proximal and distal hand grip with proximal lower limb weakness, or distal myopathies, dropped head, wherein they have neck extension weakness, can be seen in myasthenia gravis, polymyositis, ALS, as well as in axial myopathies. So based on history and examination itself, we can find out which pattern the patient fits